The issue of how long to continue bevacizumab has been an ongoing question for those of us who are treating patients with metastatic colorectal cancer. Axel Grothe, initially in the BRIGHT observational trial, provided some very interesting data suggesting that bevacizumab beyond disease progression after the first line of treatment was associated with significantly improved median overall survival, approaching 30 months. In contrast, in patients who did not continue on bevacizumab in the second line setting, their overall survival was approaching 20 months. Based on the TML study, which was a large randomized study looking at this issue of bevacizumab beyond disease progression. This study was initially developed by the German AIO cooperative group and then expanded to other European sites. This study was led by Dirk Arnold and his colleagues. I think that study clearly showed that there was benefit to continuing bevacizumab beyond disease progression and treating patients in the second line setting. There are, interestingly enough, two other anti-VEGF agents. One is aflibercept and the other one ramucirumab. Both of these agents have also been approved in the second line setting in combination with the FOLFIRI cytotoxic chemotherapy backbone. However, in contrast to bevacizumab, I think both agents are associated with increased toxicities, and also both of those agents are associated with increased costs. And then when one looks at the benefit of continuing bevacizumab versus the benefit of adding those additional agents, the improvement in median progression-free survival approaches 1.5 months. So from my perspective, bevacizumab is very well handled, very well tolerated. We know the side effects well. We have data now to support continuing bevacizumab in the second line setting. Now that we're in November of 2015, almost a year after the start of her therapy, this patient now presents with additional lesions in the liver, as well as retroperitoneal masses and lesions in the pelvis. So clearly this patient now has disease progression. It's clear that the patient now has to undergo a change in her therapy. It's interesting, the patient has been treated with FOLFOX plus bevacizumab for 11 months now. When one looks at the most recent data presented by Dr. Vanook in the CALGB 80405 study, when one looks at the median progression-free survival in patients treated with FOLFOX plus bevacizumab, that median PFS is exactly 11 months. So this patient is kind of following exactly what we would expect for patients being treated with this regimen. The patient now also is symptomatic, and presumably symptomatic from both the liver lesions as well as the lesions in the abdomen and pelvis. With respect now to second-line therapy, the patient has progressed on oxaliplatin-based chemotherapy. So the most appropriate treatment option now to consider in the second-line setting is irinotecan-based chemotherapy. It appears that the patient's overall performance status is still quite good. She's experiencing tumor-related symptoms. Quite appropriate to consider an irinotecan-based regimen in combination with either infusional 5-FU, so that would be the FOLFIRI regimen, or it would certainly be appropriate also to consider combining irinotecan plus the oral fluoropyrimidine capecitabine, and that regimen is known either as Xaliri or Capiri. And as we talked about previously, quite appropriate to continue bevacizumab in the second line setting in combination with the irinotecan-based combination. For patients whose performance status is, I think, poorer than what this patient has, so a patient's performance status perhaps 2 or more tumor-related symptoms, one might consider single-agent irinotecan in combination with bevacizumab. But again, I think for this patient, still very young, still overall performance status very good, no other comorbid illnesses, I would tend to be still pretty aggressive and go with an irinotecan combination plus bevacizumab. When one thinks about the various factors that need to go into the decision-making process, I think first and foremost, performance status, presence or absence of comorbid illnesses, previous therapies, and then also presence or absence of underlying liver and or kidney dysfunction. The issue of underlying liver function is especially important in this case because as we're now thinking about switching over from oxaliplatin-based chemotherapy to irinotecan-based chemotherapy, as we all know, irinotecan is metabolized pretty heavily in the liver. So it's critically important that the underlying liver function is normal. I think we all now appreciate that the multidisciplinary care is critically important, not only for patients with metastatic colorectal cancer, but really should hold for all patients with colon cancer. So both patients with advanced disease as well as patients who have early stage disease. In this patient, the patient has unfortunately widespread liver disease, has involvement of both the retroperitoneum and the pelvis. Surgery is probably unlikely in this case. However, the goal, even for patients who are deemed to be surgically unresectable up front, is to see whether or not whatever treatment regimens we're giving to a patient, we might be able to render that patient surgically resectable. So even though it does appear that this patient has widespread metastatic disease, surgically unresectable, we would certainly get our surgical GI oncologist to weigh in as to whether or not they're surgically resectable and at what point they would deem the patient to be surgically resectable. I think based on the Institute of Medicine report that came out a couple of years ago, it's now critically important that we consider supportive care for all of our patients who come to our clinic, even at the very first visit. This patient, supportive care, symptom management, critically important because this patient has tumor-related symptoms. So pain relief is going to be very, very important. In patients with colorectal cancer and other GI cancers, nutrition is also a very important element. And so part of the multidisciplinary approach to this patient, we would have this patient and their caregivers see our dietitian/nutritionist to have them provide a nutrition plan. And then for those patients who may be undergoing either psychological or emotional stress, either resulting from the disease itself or from the treatments, our group here at the University of Pittsburgh Cancer Institute, we're fortunate enough to have a psycho-oncology behavioral medicine program. And so for any patient who has any kind of emotional issues, we will refer those patients to that group. Again, they're part of our multidisciplinary approach to patients with colorectal cancer.